Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'll be your host for our program tonight on cancer, prevention, diagnosis, and treatment. The success of this program is very dependent on you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Bassem Gweli, a medical oncologist with St. Luke's Oncology and Hematology Associates. Dr. Dan Nikovich, President and Chief Medical Officer of Essentia Health East Region and a medical oncologist with Essentia Health in Duluth. And Dr. Eric Sather, a family physician with Essentia Health Lakeside Clinic. Our medical students answering phones tonight are Christy Freiberg of Princeburg, Minnesota, Samantha Harder from McGregor, Minnesota, and Melody Shepard of Lake Burton, Minnesota. And now on to tonight's program on cancer. Well, Dr. Gweli, maybe we should just start out with just a real basic question. What is cancer?
So I always tell my patients that cancer is essentially when a cell that typically would grow in a very regulated fashion starts to grow in an uncontrolled manner. To me, that's kind of the easiest way to think of cancer.
Thank you. And Dr. Nikovich, obviously there are many types of cancers. Is there anything common among them all, or is it just a wide variety?
I think there's a wide variety, Dr. Johns. There's some things in common. There are some genetic disturbances that are common in some types of cancers, in colon cancer, for example, or in breast cancer. There's other cancers that have things in common, for example, in leukemias. But to say there was one common thread to every single cancer, I don't think we know that. Perhaps it exists, but it's not yet been identified.
Thank you. Dr. Sather, is there types of cancer that you can screen for, and how do you do that?
Absolutely. We typically like to cover that, say, at your physical. It starts typically around, it depends what we're looking for. For women, it starts earlier. Usually we start with cervical cancer screening in women starting around age 21. And that goes on through about age 65, depending on risks and things like that. For the other types of cancers that we screen for in primary care, breast cancer through mammograms and breast exams during a physical. For men, usually starts a little later. Things that we typically screen for, like colon cancer and prostate cancer, starting about age 50. And there's other kind of cancers, but sometimes we don't screen for every kind. Like we might do exams to look for them, but not maybe on everybody. It depends on their risk factors, things like testicular cancer, ovarian cancer, bladder cancer, things that we don't always test for at every physical, but we might talk about. If you're at higher risk, we might say we should test you for that kind of thing. So
let me ask you a follow-up question. You're a family physician. A lot of this cancer screening really takes place in primary care physicians' offices. Yep. Is that right? That's the place to go.
Yeah, and it really depends on a person's risk factors and their age and like family history. And as we're doing your physical and getting that information, we can talk to you about what your risks are and how do we test for certain things, and what do those tests mean when we get the results back. So,
thank you. Dr. Gweli, we have a caller from Clover Valley that would like to know, what are the symptoms of multiple myeloma and is it genetic? Maybe just mention a word about multiple myeloma.
So that's a great question. So multiple myeloma is a cancer of a plasma cell. So plasma cells typically are a component of your immune system, and they generate antibodies, so they help fight various infections. So multiple myeloma is when a plasma cell basically acquires a particular genetic mutation complement and can begin to grow in an uncontrolled way. And so typically with multiple myeloma, we look for four things essentially. So we're looking kind of at blood tests and we're looking at symptomology. So the biggest symptomology associated with multiple myeloma that is of concern to us is bone pain. So multiple myeloma can present with lytic lesions in the bone, and that can often manifest with significant bone discomfort. So that's kind of the big thing that we look for from a symptom perspective. However, with that said, multiple myeloma can also cause anemia. So anemia can manifest with fatigue that you didn't really have before. And it can manifest with shortness of breath with activity that you're unaccustomed to having when you exert yourself. It also, when we look at multiple myeloma, we look for two other things particularly. We look for an elevated calcium because oftentimes with infiltration of the bone from multiple myeloma, you can get a release of calcium because the bone breaks down. And the last thing we look for really is renal dysfunction. So renal dysfunction is kind of an odd symptom. A lot of patients don't necessarily feel renal dysfunction because you have to have kind of profound renal dysfunction to really begin to feel it, in the sense that you don't urinate as well anymore, you don't urinate with the same volume. But really it's those four things that I'm looking for when I think of someone with multiple myeloma.
Thank you. Dr. Nikovich, we have a caller from Proctor who would like to know, could you please discuss neuroendocrine cancer?
Well, it's a broad category they're typically cancers that might secrete certain substances that can cause a variety of different symptoms. There are things called carcinoid tumors that can be present in a variety of places. Commonly, they're in the bowel. And in fact, it's the primary reason why when someone has an appendicitis, that appendix is sent by the surgeon to the pathologist, because about 1% of the time or less a carcinoid tumor would be identified in the appendix. And if so, that could prompt additional surgery for that particular patient. Carcinoid tumors can be found other places in the body, the lung being one. Sometimes they can secrete substances into the system that can cause things like wheezing, flushing into the face, diarrhea as well. In advanced enough cases, it can even cause problems with the heart, valvular dysfunction in the heart, and right-sided heart failure. Neuroendocrine tumors are also in the lung. There's a variety of non-small cell lung cancer, a neuroendocrine tumor of the lung, also in the pancreas as well. And it's a diagnosis that is made largely by the pathologist, but we sometimes have clues, especially if there's a lot of symptoms, as I mentioned, when someone has really wheezing, diarrhea, facial flushing, and there's no other explanation for it. And it can prompt you to think about a carcinoid tumor, which we know to be neuroendocrine.
Thank you. Dr. Sather, we have a caller from Two Harbors. This is, how can you prevent skin cancer? I'm sure that comes up in your office.
Biggest thing is protect yourself from the sun. Try to limit sunburns, use sunscreen, use protective clothing, and then make sure you're getting a good skin exam when you see your doctor. If you see something that's growing or changing, things that different colors of pigment in the same skin lesion, or something that's just not healing up, get it checked out, and often we can do a biopsy right there in the clinic and see what it is. If it's something concerning, make sure we get it out completely and send it to the right people to take care of it.
It's a very common presentation for you, I'm sure.
Yeah, we see a lot of that in the clinic. So,
Dr. Gwelly, we have a caller from Duluth with this question. Once you've had cancer, how common is it to get cancer in a different spot?
Well, that's a tough question. So
I know.
it really is predicated on what the cancer is that you had and why you had it. There are some genetic issues that can, for example, result in breast cancer, which would then predispose you to other tumors like ovarian or pancreatic or what have you. So that's a very tough question to answer. I think the vast majority of tumors oftentimes recur in the same manner. So breast cancer, for example, we typically worry about breast cancer recurrences in the breast as opposed to worrying about a lung cancer or what have you. It's a complicated question now.
Yes, thank you. Dr. Nikovich, here's a caller from Chisholm. This is a good question too. Why isn't the CA-125 screening test done for ovarian cancer? And why isn't that included in all women's exams?
Yeah, that's an excellent question. It comes up. I think all three of us have had that question. And the reason is that when it's been studied as a screening tool, it's not been found to be an effective one. And we screen our patients for cancer because the screening tool can help improve survival. And can detect a cancer early, and by intervening early, you can make a difference. And the CA-125 has not been an effective test in that regard. It is a test that we will use after a firm diagnosis of ovarian cancer has been made, as a way that you can have clues as to whether it's recurred, whether it's responding to therapy, or whether in fact it's resistant to therapy. A similar thing would be CEA level in colon cancer, not something we can use to diagnose or screen for colon cancer, but it is a test for some patients we can use to assess whether there may be a recurrence. So the CA-125 test, yes, it sounds good, but there's insufficient data to support it as a screening tool.
Let me ask you a follow-up question
Yeah.
then. Are there any good screening tests for ovarian cancer?
There are for certain high-risk women, and for a woman that would possess a BRCA gene mutation, for example, and that might be less than 5% of the population, and they'd be identified often by their personal or family history. We can do CA-125s in those women. We can do regular pelvic ultrasounds on those women as well. So there are some for a very select group of patients, for a very select group.
Broad-based
But as a
testing.
broad-based thing, no. Unfortunately, we don't have one now.
Thank you. A caller here's a caller from Two Harbors, Dr. Say. They're wondering about Barrett's esophagus. Is that something that can turn into cancer, and is that something that's just treated with acid reflux treatment?
Absolutely can. Barrett's esophagus is caused by chronic reflux and inflammation in usually the lower esophagus. Over time, the cells change from esophagus lining type to what looks more like your intestine. And when cells change, they can mutate, the DNA can mutate and then become cancerous. So if you have this Barrett's esophagus, it's kind of a precancerous condition where these cells have already changed because of this reflux damage. And so if you have Barrett's, we typically put you on an antacid type medication called a proton pump inhibitor, is the most effective kind. And then you would need to get checkups regularly, get a scope down the throat, what we call an EGD, to take a look and do biopsies if necessary to see if that's changing from a precancerous condition to a cancerous one. And then if it is, get it treated.
Thank you. Dr. Gwelly, I asked you a question about multiple myeloma. We have a caller from Hermantown with this question. I was diagnosed with Waldenstrom macroglobulinemia, but I don't know what to expect.
Well, so Waldenstrom's macroglobulinemia is unique in that it's not something we typically can cure. I guess it's like multiple myeloma in that regard. It's not a disease you can really cure. It's one of those that you essentially treat when you need to treat. When someone has symptoms related to the disease, you kind of push it back, and then as someone can be, after you do that, you can essentially have someone in a remission where the disease really isn't active. It's kind of quiescent. And then when it causes a problem, you address it again. So symptoms that you can look for in that context are related to kind of what we call a hyperviscosity syndrome sometimes, where you can have vision issues, you can have some fatigue associated with exertion. In addition, macroglobulinemia can also manifest with some anemia, with cytopenias, etc. But really it's kind of a more complicated sort of picture.
Thank you. Dr. Nikovich, we have two callers here with somewhat similar questions, one from Ely, one from Moose Lake. One asked, please discuss leiomyosarcoma, and then another one, caller wonders about angiosarcoma. So tell us about the sarcomas.
Okay, well, sarcomas tend to be more uncommon cancers that we would see. Leiomyosarcoma clearly is a more common one among that. Sarcomas are cancers that arrive from connective tissue. So muscle, cartilage, also they can be in the lining of the blood vessels, as with the second question about an angiosarcoma. And a leiomyosarcoma can, a common place it might arise in an adult would be in the muscle of an extremity, is where we might see it. It also can be somewhere in the abdomen. The best therapy for it is surgical, to remove it. Sometimes we'll treat it afterwards with radiation therapy. Sometimes with chemotherapy. Chemotherapy for sarcoma typically is utilized if in the unfortunate situation that it's recurred or it's spread. In an angiosarcoma, that's a rare tumor. And any of us in a long career in oncology, you may see 3, perhaps 4 or 5 patients in your career that would have that. And it arises from the lining of the blood vessels. It's a difficult thing to treat. It tends to be one that presents after it's already spread. Someone can present short of breath, for example. Sometimes we see it involving the heart even. And unfortunately, it does not respond very well to chemotherapy. There's some chemotherapy drugs we have for it that can be utilized.
Sure.
It's a very rare tumor. I think the key thing about sarcomas also to know is that the diagnosis, you have to be comfortable with the pathologist that makes that call and who knows about sarcomas and can make the correct diagnosis on it.
Oh, thank you. Dr. Sather, here's a question that comes up a lot, and I'm sure you've heard this one before. Does a high PSA mean cancer? Caller from Aurora.
Not necessarily. It can. PSA can be elevated from several things. Prostate cancer being one of them. Enlarged prostate sometimes can cause a mildly elevated PSA. Prostate infection can cause an elevated PSA. Sometimes during an exam, we do a rectal exam and touch the prostate, and that maybe very mildly elevates it, but usually not significantly so. And if it's on the borderline, we can recheck it if we didn't do a rectal exam and then see if it's still normal or a little high. So that it's not PSA is not specific to just prostate cancer. There's other things that can make it go up.
Okay, thank you. Dr. Gwilly, caller from Duluth wonders about tumor markers in pancreatic cancer. I guess there are tumor markers, and do they fluctuate?
Yeah, it's a great question. So the tumor marker that we look at in pancreatic cancer is a CA19-9 marker. And there's some data to suggest that it can help lead you to a diagnosis of pancreatic cancer where if you have a tumor marker greater than 1,000, it's a 98% positive predictive value for having pancreatic cancer or some hepatobiliary tumor. But the bottom line is we oftentimes use the marker kind of as a guide. So if the marker comes down with our treatment, it suggests that our treatment's working because the marker is essentially made by the pancreatic cancer cells. So if you're killing the cancer cells, there's no source for the marker to be made. So it certainly can fluctuate with the status of the disease. So if the disease gets worse, it can certainly rise. And so it's sometimes a very nice surrogate measure of what's happening with pancreatic cancer. Actually, it is for us.
Thank you. Dr. Nikovich, we have a caller from Esco and Duluth, both wondering about pain, joint pain during chemotherapy. And is it common? Does it go away after chemotherapy? And one caller wondered if you're having pain persisting throughout chemo, does that mean that it's not working?
Yeah, well, very good questions. I think it depends on the circumstances of the situation. Chemotherapy can cause bone pain, and there are certain types that can. There's a chemotherapy drug, a common one we'll use, it's known as Taxotere. That can cause bone pain. Another one called Taxol sometimes can cause bone pain. The other thing that can cause bone pain sometimes is a drug that we'll use to stimulate the bone marrow to make more white blood cells after chemotherapy. It's called Neulasta, and that can cause bone pain itself. And when you use that plus the chemotherapy drugs, it can at times be challenging to figure out what's what. Where's the pain coming from? Typically, bone pain from chemotherapy or bone pain from Neulasta can be readily treated, often with a drug known as dexamethasone, or other pain medicines sometimes can be utilized. If someone has cancer and it's in their bones, and the symptom of that cancer in the bones is pain, and they're receiving chemotherapy, yet the pain persists or progresses, yeah, that would be worrisome. And you'd wonder maybe it's not responding.
Sure.
Yeah.
Thank you.
Could chemotherapy accelerate degenerative joint disease, arthritis?
I don't know that it could accelerate it. We've seen patients with, certainly with inflammatory arthritis, sometimes even with osteoarthritis where it does improve with chemotherapy. The other thing I'll note, as long as you mentioned about bone pain, another common drug that causes it is a drug that we will use in the setting of treating women with breast cancer. They're called aromatase inhibitors, and the common drugs would be Arimidex and Femara or exemestane. They are known to cause arthralgias or bone pain.
Sure.
So, and we have to be mindful of that.
Will that tend to go away then when the chemotherapy is over?
It does tend to go away when those drugs are used. And there's some interesting data that if someone's vitamin D deficient and they take a drug like Arimidex, it can actually make that bone pain. It's particularly advanced, and if you supplement the vitamin D, it may get better.
Oh, interesting.
Yeah.
Here's a caller from Aurora with specifically for Dr. Sather. Now, this is an interesting question, and anyone can jump in on this. Will there ever be a cure for cancer?
Wow, it's such a broad, cancer. Like we mentioned earlier, there's so many types of cancer, and
So there
it's
are
not
cures
just
for some of them right
not
now.
just like one kind of. Can't say cancer. Every type of cancer is different, and right now, sometimes it's management, or we can't cure it, but we can slow it down, or and then some are curable, but maybe someday. Right now, it's you know.
You know, one thing that's happened about it may be a change in the paradigm of thinking, in that we've of course want to cure cancer, but some of our therapies that we have available to us now are very, very effective at controlling it, and so the paradigm change may be from not going from cure to making it into a chronic disease.
Sure.
And then at the same time making sure that someone can have an acceptable quality of life with that.
I think one thing that I'll say is I find that the field of cancer is burgeoning at an incredibly rapid rate. There are new drugs coming out every single day that you hear about that are in trials, and it's actually quite overwhelming as an oncologist and hematologist to have to just learn about all the new drugs coming out. So there's certainly a remarkable amount of research taking place in this area, and so we'll see.
Very good. Can you, Dr. Gwelly, caller from Duluth wants to know, can you talk about Burkitt's lymphoma?
Yeah, so Burkitt's lymphoma is a very aggressive type of cancer of a lymphocyte, which is a cell that's in the immune system. It's a B lymphocyte, and it's oftentimes a result of a translocation that takes place between chromosome 8 and chromosome 14, essentially causes that particular cell to grow in an uncontrolled way. Now, Burkitt's cell lymphoma is unique among B-cell lymphomas in that it's a remarkably aggressive tumor. But with how aggressive it is, it actually is a very highly curable lymphoma, among the most curable lymphomas that we have. And it's unique among cancers because it is actually a very curable disease on the order of 80, 90%. So Burkitt's lymphoma, very aggressive lymphoma, can present incredibly rapidly. But the advantage there is that because these cells divide so much, they're exquisitely sensitive to chemotherapy, and oftentimes you can cure it.
Very interesting. Dr. Nikovich, caller from Duluth, would like to know about non-Hodgkin's lymphoma, and does stem cell treatment, or stem cell transplant, I should say, help survival with that?
Well, yeah, well, non-Hodgkin's lymphoma is the most common type we'll see in the United States. And there's actually about 33, 34 different subtypes depending on the histology. And we do use stem cell transplant for certain types. And for example, a non-Hodgkin's, or rather a diffuse large B-cell lymphoma that has relapsed after initial therapy for curative intent. If that relapses and then subsequently we can get that patient's lymphoma to respond to another course of chemotherapy. In other words, we call that chemotherapy sensitive. Then going to an autologous stem cell transplant is standard of care, and it can help that patient, and that's done for curative intent.
Sure.
Without a stem cell transplant in that situation of the large cell lymphoma, the likelihood that you'd cure someone after a relapse is fairly low. Still possible, yes, but low. We use it for other circumstances as well. Sometimes with follicular lymphoma, we may use that, a transplant. Mantle cell lymphoma, which is an increasingly common lymphoma in patients over age 60, we would also utilize a stem cell transplant.
Thank you. Well, we're getting down to our last minute or two here. Dr. Sather, caller from Cloquet, do all types of cancer show up in blood work?
No. There are certain tests or certain cancers that we can test for, and some of them do, but I wouldn't say that all of them do. Like there's, like with skin cancer, they don't have a good blood test to test for that, so.
So there's more than just doing blood tests to diagnose it.
Yeah. Good exam, and even then, sometimes we can't catch them all.
And history too, and all history and physical.
Yeah, we try.
Very good. Caller from Hibbing would like to know, why does testicular cancer spread so rapidly? It's a characteristic of it, but.
Well, I don't know that testicular cancer spreads all that rapidly relative to other tumors. I think, testicular cancer we oftentimes catch at a very early stage, and is highly curable in that regard. So I don't know that it really is a typically rapid growing tumor. So it's hard to answer that.
Okay.
From my perspective, it's no more rapidly growing than a lot of other tumors we deal with.
Thank you very much. Well, I guess I should say that we're getting near the end here. So thank you very much for your participation tonight. I'd like to thank our panelists, Dr. Bassam Gwilly, Dr. Dan Nikovich, and Dr. Eric Sather. And our medical students, Christy Freiberg, Samantha Harder, and Melody Shepard. Next week, please join Dr. Ruth Westra for a program on upper GI problems, when her panelists will be Dr. Johan Bakken, Dr. Aga Bednarz, and Dr. Paul Sanford. Thank you for watching, and good night.